will start the next session. Dr. Jamal.
هو موجود؟ هو ده. لا مش هو ده. Now we are going to start the plenary lecture of HIPEC in the management of peritoneal metastases, how to select the good candidate. By Professor Olivier Glyn from France.
Okay, thank you. And thank you to the organizing committee for the invitation. This is my first time in Egypt, and I will be very happy to help you to select the good candidate for a curative approach for peritoneal surface malignancies. I have the chance to be at the head of peritoneal cancer expert centers, and I follow my boss, Professor Gilly, that did the first IPEC in 1989. We are performing a lot of cytoreductive surgery procedures combined with IPEC for many etiologies: ovarian cancer, colorectal cancer, and gastric cancer, with the help of this big team. Okay. When I started my residency, peritoneal surface malignancies were considered most of the time as a terminal condition, and the median survival of these patients operated was not more than 7 months. Progressively, year after year, with the development of cytoreductive surgery, of intraperitoneal chemotherapy combined with it, with a more appropriate patient selection, as you can see, we increase for every etiologies or curative procedures, and we have now a median survival of more than 60 months. But how to select the good patient for the good surgery? We should take into consideration first the patient condition, the age, the motivation, and the performance status. Of course, these kind of procedures cannot be performed everywhere, and you must have the good surgeon, a multidisciplinary team, and be able to perform intraperitoneal chemotherapy. You should also select your patient regarding the peritoneal disease, the extent, of course, the possibility of complete cytoreductive surgery. And finally, you should also select your patient regarding the tumor. What is the etiology? What is the response to systemic chemotherapy? What is the pathology? And we will see today also what are the molecular factors. But regarding the results that we have now, the first message and the most important message in front of one peritoneal surface malignancy is that a curative treatment should be considered at the time of the diagnosis and not after failure of several palliative treatment, systemic or surgical. This is still an aggressive therapeutic approach with, as you know, mortality rate reported from 2 to 10%, morbidity rate from 20 to 50%. So you have to select your patients regarding the general status, and of course regarding also its psychology and its motivation. Performance status should be from 0 to 1. There should not be any cardiac, respiratory, or renal severe disorders. You should schedule your procedure 1 month after the last cycle of chemotherapy, and your patient should believe into the treatment. What about age? Age was for many years a relative contraindication over 70 years. We looked into our French registry for patients treated before and after 70 years, and even if you can see that the mortality rate at day 90 was a little higher for older patients, the morbidity rates were exactly the same, and this difference was not significant. So age today does not constitute an absolute contraindication for this kind of procedure. The centers where the procedure is performed is very important, and this procedure should be performed in centers that are allowed to perform complex procedures. This is complex and costly and long procedure. You will have a better patient selection, you will have a lower complication rates, and most importantly, you will have a higher rate of curative complete cytoreductive surgery. So as soon as you are diagnosed peritoneal surface disease, you should contact expert centers in the management of peritoneal surface malignancy. This is not always easy to take the decision intraoperatively to go on or not. You should take the good decision regarding the extent of the disease, regarding the removal of organ of peritoneum that you should do to perform a curative procedures. And I don't know if you like Western, but I like Western, and especially this Western from Sergio Leone that illustrates, I think, very well the position of the surgeon during a cytoreductive surgery. You could be the ugly, so perform inadequate cytoreductive surgery, let some residual disease, and jeopardize the chance of your patients to have a curative procedures. You should also be the bad. The bad will do cytoreductive surgery, whatever the extent of the disease is, leading to a very hard postoperative complication or to bad quality of life. So you should be the good, and it's not always very easy to be the good, and you should help yourself by a multidisciplinary team. This is the reason why the French National Cancer Institute decided to establish in France some expert centers, some reference centers, and some specialized time that are able to take in charge this peritoneal surface malignancy. And it concerns not only the surgeon, but also the pathologist, also the radiologist, and also the medical oncologist, because this management is a multidisciplinary management. So which etiology now? The probably best indication is for a rare peritoneal disease, peritoneal mesothelioma. You can see in blue the median survival that is obtained with systemic chemotherapy alone. Here, the median survival obtained with cytoreductive surgery combined with IPEC. IPEC was an independent prognostic factor in these big registries for this etiology published in the Journal of Clinical Oncology. The other best indication is for pseudomyxoma peritonei. You can see that IPEC with closed or open procedure did better than intraperitoneal chemotherapy without it, and that you may obtain very long-term survival by these combined procedures. Even if you have a big amount of disease, in this case of a very extensive pseudomyxoma peritonei, when you open the abdomen, you don't know exactly where you are, but this patient was able to be treated by a complete cytoreductive surgery and IPEC and is alive without any disease 10 years later. For ovarian cancers, 2012 was a big year for the demonstration of the IPEC, and we had a positive phase 3 trial that was published by our Dutch colleagues in the New England Journal of Medicine. That demonstrated that for patients that are not able to be completely resectable at the time of the diagnosis, that if you are performing IPEC in combination to an interval complete cytoreductive surgery, you gain a strong benefit in terms of recurrence-free survival and more than 1 year in overall survival. Anti-angiogenic therapy that is given to every patient with ovarian carcinomatosis today did not demonstrate a so big benefit. But what about the most common indication, the colorectal peritoneal surface, colorectal peritoneal metastasis? You can see that since during the 20 past years, every 10 years we gain 10 months of median survival, even in the last studies published by the French group that demonstrate that cytoreductive surgery alone in selected patients may obtain 40 months of median survival. What about this study that was presented in the last ASCO meeting? We decided to evaluate the role of IPEC in the combined treatment cytoreductive surgery and IPEC. And the IPEC that was evaluated was IPEC using high dose of oxaliplatin for 30 minutes combined with 1 perfusion of 5-FU. And unfortunately, this study showed that IPEC increased the morbidity at 60 days, and that the IPEC did not really increase the benefit, the median survival and the overall survival in comparison to cytoreductive surgery alone. So, if we are doing a quick conclusion of this randomized phase 3 trial, we can say that IPEC did not improve prognosis of patients curatively treated for colorectal peritoneal metastasis. But this is not the adapted conclusion. The adapted conclusion is that IPEC with oxaliplatin with high dose for 30 minutes at 43 degrees did not improve prognosis of patients with colorectal metastasis. We probably did not the good choice of IPEC in our randomized phase 3 trial. Why? Because when you look at the effect of oxaliplatin without 48 hours of 5-FU, this is probably less than 10%. Because this IPEC leads to a higher rate of complication and a higher rate of hemorrhagical complication that have a strong bad impact on overall survival. This is probably an insufficient duration of heat of drug exposition, and the carrier solution is probably not adapted because the glucosate that was used is a procarcinogen and limits the defense of the peritoneum. What about gastric peritoneal metastasis? I will have a lecture on Friday, and I will go for this indication more in detail. But there is sometimes also unusual indication of curative treatment for peritoneal surface malignancy. And we did recently, into the PSOGI international group, large retrospective study that combined a lot of procedures and a lot of centers. I have no time to go into details, of course, but I will just show you some examples. Peritoneal metastasis from cholangiocarcinoma, for example, which is a bad prognostic disease. You can see that when we compare in selected patients that had cytoreductive surgery and IPEC to case control group treated with only systemic chemotherapy, we had a strong benefit in favor to the combined treatment in selected patients. We have the same results in other peritoneal surface malignancy like urachus tumors, like some pancreatic tumor. So the etiology is not an absolute contraindication for this indication, and you can see here what is today recommended in France for combined treatment, cytoreductive surgery, and IPEC. What is now how we can, we must select the patients regarding the peritoneal disease. The two most important factors, whatever the etiology is the possibility of complete cytoreductive surgery, and the disease extent evaluated by the peritoneal cancer index. You can see that in colorectal cancer, in pseudomyxoma peritonei, that the completeness of cytoreductive surgery represents the most important prognostic factor. You should be able to resect all the macroscopic disease. This is also the case in gastric cancer and in ovarian cancer. But there is another very important prognostic factor. This is the disease extent evaluated by the PCI, which is a tool that is perhaps for surgeons that are not using it so much, not so easy to complete. This is the reason why we developed this internet tool that allows each surgeon to complete the peritoneal cancer index, and that to add to his operative report this PDF that summarizes the extent of the disease. As you can see, in colorectal carcinomatosis, the PCI is also a very important prognostic factor. In every registry, each time you gain 1 point of PCI, you are losing 5% of survival. It's finished. Okay, I will go fast. This is also an important prognostic factor, of course, for gastric cancer. So, what is the very important message? In all cases, when you are in front of peritoneal surface malignancy, you should evaluate the possibility of complete cytoreductive surgery, and you should describe precisely the extent of carcinomatosis. Of course, laparoscopy is a pivotal tool to appreciate this extent, because many times on the small bowel you may have this small disease that is not visible on morphologic exam, and that should be described, because this disease on the mesenteric wall of the small bowel, this small granulation diffuse on the small bowel will be a contraindication of complete cytoreductive surgery. What about the extraperitoneal disease? This is not an absolute contraindication if this is treatable with a curative intent and if it's chemosensitive. We have some example with synchronous liver metastasis, and you can see here the curve obtained in specialized centers when you have less than 3 metastases. When the metastases are responding to systemic chemotherapy, you can do both curative treatment, liver surgery, and peritoneal surface malignancy surgery. And to finish, we should take now into account, of course, the molecular tumor factor. Here in this recent retrospective study, this group showed that the BRAF and the RAS mutation had a strong prognostic factor, so we will have to take it into consideration in our selection process. So, as our colleagues, our medical oncologists that developed personalized treatments regarding the tumor, the patient, the extent of the disease, we will have also to develop this personalized therapeutic management for the curative treatment of peritoneal metastasis. Thank you for your attention.
Thank you very much. Any questions? I have a question. I have attended the last conference in Paris and I met you there. And I think Sugar Baker, when he gave his lecture, he said we should continue on the same, and we try to have more studies, because the French results were disappointing. What's your opinion?
Yeah. This is what I showed you. Of course, the French results are disappointed regarding the role of IPEC that we chose, but not regarding the median survival that we obtain. Now, with an adapted systemic chemotherapy and with complete cytoreductive surgery, we know that in colorectal carcinomatosis, we may obtain median survival that are more than 40 months. But as I said, the IPEC that we chose, oxaliplatin for 30 minutes, it's probably not a good choice because we missed the role of the intraperitoneal drug. Oxaliplatin is not working more than 10%. We missed the duration of hyperthermia. 30 minutes is not sufficient. We missed the duration of drug exposure. 30 minutes of exposition of drug is probably not sufficient. But we choose the oxaliplatin because of the pressure of the medical oncologist. I think that today the best drug to use is mitomycin C because we have an experimental demonstration, because this drug is potentiated by heat, because we have great results in pseudomyxoma and mucinous peritoneal disease, and because we have some protocols with a longer duration, with a longer exposition. So in France now, we will evaluate the role of IPEC with mitomycin C.
Thank you.
Do we have any more questions from the floor? Okay, thank you very much.